And thank you, Dr. Rajshekhar, for inviting me. He has taken me out of my comfort zone this time because, like all of you, I have used the Oxiris, Polymyxin B, Hemoperfusion cartridges, Cytosorb. But what I'm going to talk about just now has not yet come to India. And we heard from Dr. Ashish Sharma this morning that the Seraph 100 will probably be available in the next few months. Now, what we are faced with today is the fact that appropriate treatment for severe bacteremias may not be available to us. In the first place, when we choose in a patient in bacteremic shock, the antibiotic, we are going empirically, we are going epidemiologically. We don't know at the time what the organism is and what it is sensitive to. So inappropriate antibiotic therapy might frequently be chosen, and we know that a delay of every hour in appropriate antibiotic therapy increases mortality by about 9%. Even if we did have the antibiotic correctly chosen, dead bacteria may still release pathogen associated molecular patterns and damage associated molecular patterns which trigger off the downstream events, and all the therapies that we have been using which targeted inflammatory mediators and cytokines are going for the downstream events rather than the root cause. So today we do have therapies which target the organisms themselves, and Dr. Anna just spoke about some of them, the Seraph 100 he mentioned, which was targeting the viremia of COVID-19. So there are many different technologies available, use of the mannose binding lectin, genetically engineered with the FC portion of IgG, magnetic nano beads, polythene beads with attached heparin. That's the Seraph 100, and this is how the Seraph 100 works. It's based on molecular mimicry, and it consists of polyethylene microbeads to which heparin is covalently attached. Now, most cells have heparin sulfate on their surfaces, and so does tissue matrix. So heparin mimics heparin sulfate, and bacteria which normally would bind in the tissues or to cells which express heparin sulfate are decoyed into binding to the heparin on the cartridge. What does the cartridge look like? It's about 9 inches long, and it can be configured either with a renal replacement therapy device or as a standalone. This is how it looks, and it's got heparin particles there, and instead of the endothelial glycocalyx to which virus and bacteria normally bind, these polyethylene beads with heparin would attempt, the heparin attempts to bind viruses and bacteria when they are present in the blood into which it comes into contact. And this is what you can see over here. This is a cell, and this is the polyethylene bead expressing with heparin on its surface, and it's competing with the cell to bind virus and bacteria. This is an electron micrograph which shows this is the cartridge, and this is how the ultrastructure of the device with heparin bound appears. So heparin, as I said, we know it for about a century since it was first successfully used as an anticoagulant, but it also has other pharmacological properties: anti-inflammatory, anti-neoplastic, anti-metastatic, anti-angiogenesis through its interactions with proteases, protease inhibitors, and growth factors. It also is released from mast cells and basophils when it interrupts the iron availability which many bacteria, including Mycobacterium tuberculosis, requires. So the molecular mimicry of heparin and heparin sulfate is utilized by the cartridge. Now, the Oxiris device, which we have already been using, is similar in the sense that the Oxiris has a polyacrylonitrile surface to which polyethylene imine is bound, and then heparin is grafted onto it. So theoretically, we might expect that if the Seraph 100 is binding viruses and bacteria, then the Oxiris cartridge should do the same. But I could not find a single report of the Oxiris having been used as a bacterial clearing device, though it has been shown to reduce endotoxin and cytokines in some studies. Now, in contrast to that, this is what a data is available for the Seraph 100. It has been shown to bind and reduce bacterial and viral loads, viruses, to the tune of 40 to 50%, different viruses, gram-negative organisms, and even Staphylococcus aureus and MRSA to the tune of 90 to 100%, depending on what situation and what schema it was used in. And it has a modest effect there is a modest effect of heparinized beads compared to control beads in reducing some cytokines and growth factors. So this is a study which was done with Staphylococcus aureus. It was the CRRT 100 was introduced into a circuit, and samples were drawn pre-cartridge and post-cartridge at various time intervals, while blood containing Staph aureus was perfused through the cartridge at a rate of 200 ml per minute. Now, within 5 minutes, the post-cartridge had a negative blood culture, and at 240 minutes, that's 4 hours, even the pre-cartridge, which by that time would have had about 48 liters of blood circulated, was also giving negative cultures in this report. And fine, so there is then how does it perform in clinical trials? This is a trial which has been published in 2022 in Critical Care. It looked at hemodialysis patients who had developed catheter-related bloodstream infections, and these patients aged between 18 and 90 years of age were submitted to hemoperfusion with the CRRT 100. The treatment was combined with hemodialysis, so it lasted about 3 to 4 hours at a blood flow rate of 200 to 350 ml per minute, and the primary endpoint in this study was really the safety of the CRRT 100, while the secondary endpoints were the time to positivity of cultures drawn after CRRT 100 treatment. And in this study, it was assumed that a differential time to culture positivity before and after treatment of 22 minutes after the cartridge would be statistically significant. Now, the safety endpoints of the study were well met. There was no real difference in the vitals of the patient after the CRRT cartridge was introduced into the circuit, but the oxygen saturation improved slightly, and we know that normally in an extracorporeal dialysis circuit, oxygenation might actually decrease, and that was significant. There was there was a single adverse event during among the 12 patients, and it was not attributed to the cartridge. The time to culture positivity was 36 minutes, with going from -7.2 to 96.3. Now, because this study was small, significant pathogen reduction, obviously this study wasn't powered, it couldn't show that the 95% confidence interval would not include 0, but the secondary endpoint of increasing the time to culture positivity, and therefore indirect evidence that the bacterial load was reduced, was met in this study. This is the COSA registry data, which was published in June 2022 in NDT by Julius Schmidt, and it looked at 78 patients who were treated for COVID-19, serious COVID-19 infections and COVID-19 RNAmia, who were treated with the CRRT 100. This is the flow. All these patients were PCR positive, more than 18 years of age. The primary endpoint was 30-day survival after CRRT 100. 78 patients were analyzed for the data out of 102 who were screened. The median CRRT treatment time was about 5 hours, and the blood volume treated was about 71 liters. One patient received 4 treatments, 3 received 3 treatments, and 11 received 2 treatments, while the rest received 1. There were 9 adverse events among 102 treatments. Now, there wasn't a significant, what was significant on multivariate analysis for mortality was concomitant bacterial infection and a delayed time of starting of the CRRT treatment. In fact, when they plotted the survivals, this is what it shows, that if losing a cutoff point of 60 hours, there was a significantly higher mortality in those patients who received the treatment after 60 hours as compared to those who received it before. Another device which has been used is called the Hemopurifier. The Hemopurifier consists of a plasma filter. In the extracapillary spaces of the plasma filter, a plant lectin from the common snowdrop plant is placed, and this, as the blood is flowing through the spaces, the plasma which is which separates from blood in the extracapillary space, the lectin present over there will bind viruses in the device. So this is the Hemopurifier, and this is how it looks. Now, it's based on the principle that the plasma filter has a pore size of about 200 nanometers, and most viruses are about 30 nanometers in size. So they would pass freely along with plasma to the extracapillary space, where the adsorption agent, the lectin galanthus nivalis agglutinin, would bind the viral particles. Now we know that in a filter of this sort, in the proximal 2/3, the pressure within the capillaries exceeds that in the extracapillary space, so that filtration of plasma will occur. And if we cap both the plasma outlets of the device, then in the distal 1/3 of the device, the pressure developing in the extracapillary space would exceed that of the blood compartment, and the plasma minus the bound viral particles would then re-enter the blood in this device. So the device has been used along with citrate anticoagulation on both the Prismaflex and B. Brown's Diapact machine in series with a normal hemofilter in this schema. And it has been tried in a case of Ebola virus disease, where we know that the treatment is, despite monoclonal antibodies, the treatment for Ebola is largely supportive, and it has a very high mortality to the tune of 70%, case fatality rate of 70%, which prompted these authors to test the Hemopurifier device. Now this is what they found: the viral load reduced by about 100% after 10 days of treatment with the Hemopurifier. They calculated that using a 1-compartment model and an estimated plasma filtration volume of 3 liters, about 88,000 viral copies were removed during 6.5 hours of treatment. And in this case report, they showed that on day 13, the virus load decreased to nil. Now this could have been the natural history of the disease also. We can't really give a complete credit to the device, because it was also accompanied by an increase in the IgG titers and a clinical improvement. They also used the device in the Hemopurifier, has also been used in the Middle East respiratory syndrome viral disease and in Marburg virus disease, both conditions which have high case fatality rates. The Marburg virus especially is known to release decoy glycoproteins and enable it to achieve what is called as immune evasion. So the Hemopurifier was meant to remove not just whole viruses, but also perhaps the viral glycoproteins which were acting as decoys. This is an in vitro study which was done with the Marburg virus, in which the the Hemopurifier device was compared with controls in 4 situations, and after a time of 180 minutes, the Hemopurifier showed a reduction in the viral load of anything between 60 to 75%, while it was about 20% in the control columns. A third approach to preparing devices which would reduce pathogens has been the biofluidic and nanotechnology. Bacteria in blood undergo what is called as stochastic movements, in which the collision rate with a removal surface will depend upon the radius of the bacteria, the Boltzmann thermodynamic constant, and the absolute temperature. And what you can see is in the denominator, there is the radius of the capture device, maybe a microbead. Now, as the radius of the capture device is in the denominator, it follows that if it is significantly larger than the particle that it is going to capture or approaching infinity, the collision constant or the rate of collision is going to become 0, and in that situation, then the device is unlikely to capture its target particles. This is where nanotechnology or nanomagnetic particles have been used to bind the FcMBL lectin, and also the property of microfluidics. Microfluidics refers to nanoliters of plasma flowing through channels which are of the range of micrometers, where surface active forces become more significant than bulk flow. In the morning, we heard Dr. Kaushik talk about laminar flow and turbulent flow. In microfluidic channels, only laminar flow occurs, and that allows surface forces to act significantly. Now, this is what has been done. This is a nanomagnetic bead to which the FCMBL, that is the crystallizable portion of IgG, bound to a mannose binding lectin which normally binds bacteria, has been genetically engineered and attached, and then a magnetic field. Once these magnetic beads have been covered by viral particles or other pathogen associated molecular patterns, a magnetic field can remove them from the bloodstream. So this is what spurred the development of a device known as the biospleen. Here is the device. What it has is two microfluidic channels. In one channel, blood flows similar to the sinusoids of the spleen, and in the other you have saline which contains the magnetic beads to which the FCMBL lectin is bound, and you have a magnetic field which is removing the nanomagnetic particles bound with virus, and an almost infinite supply of fresh magnetic particles can be fed into this. The limitation to this device is that because the channels are microfluidic in nature, the flow is restricted to about 15 ml per minute. And so the Garnet hemofilter came as an improvement of the biospleen. The Garnet hemofilter uses a standard polysulfone hemofilter and allows an increase in the blood flow from 15 ml per minute to the normal blood flows of 200 to 250 ml used in continuous renal replacement therapy. What the hemofilter has is to the immobilization on the polysulfone fibers of the hemofilter, the FCMBL lectin. So it combines the ability to do both a renal replacement therapy along with an absorption of infective particles, also endotoxin to some extent, and also pathogen associated molecular patterns. The device has been described in detail in papers between 2015 and 2018. It has been tested both in animal studies in septic Wistar rats as well as in vitro with various with Staphylococcus aureus and E. coli. The device was made for in vitro use using polysulfone hemofilters made by the next stage, and with for use in rats with microcos filter systems. And this is a study which was reported in Biomaterials in 2015, that it showed that here you have, they used E. coli and Staphylococcus aureus in vitro, and also they tried it in septic rats who were submitted to treatment with the Garnet hemofilter on a micro scale. There was a so as I said, there was a significantly increased flow capacity as compared to the biospleen, and the Garnet hemofilter was tested for its ability to remove intact bacteria, pathogen associated molecular patterns, and endotoxin. And this is what was shown. The cleansing efficiency for Staphylococcus, for E. coli and lipopolysaccharide endotoxin was to the tune of 80 to 90% after a 4-hour treatment, and this is what happened to the E. coli counts from the blood when compared with a control filter. There was a 3-log reduction in that from the Garnet hemofilter as compared to the control, and there was also a 2-log reduction in endotoxin. When they tested it after antibiotic therapy, they found a synergistic improvement, so that the antibiotic therapies which caused bacteria to release pathogen associated molecular patterns, the PAMPs were removed by the Garnet hemofilter in this way. So these 3 strains of E. coli were tested both with viable bacteria and with bacteria which had been killed by susceptible antibiotic, and the cleansing efficiency was the same. When they looked at the recovery of organisms from the various organs after sacrificing the rats following a treatment with the Garnet hemofilter, there was a significant reduction in all the recoveries from all organs of the rats as compared to the control filter, and there was also a decrease in the colony forming units and the endotoxin levels. When they looked at what happens after antibiotic therapy, now this is untreated. The blue bar is the untreated animals, the red bar shows antibiotic therapy alone, and the green bar is showing the organism density after treatment with both antibiotics and the Garnet hemofilter. Now at 0 hours, there's round about the same amount of bacteria. At 8 hours after antibiotic therapy, there is a sharp increase in the PAMPs. And that is because the antibiotics have caused liberation after killing the bacteria. And when the Garnet hemofilter was added, you can see at 10 hours, the PAMPs have reduced significantly after use of the hemofilter. The last device which has been used makes use of the fact that the human leukocytes themselves can be modulated by CRRT in the presence of low calcium levels. When the leukocytes can be caused to be separated by a membrane in an atmosphere of low calcium, leukocytes undergo a process of binding, apoptotic conversion, and when they are released back into the circulation, they undergo a programmed cell death. So, the selected cytopheretic device, which consists of tubings, connectors, and a membrane cartridge, it's made by C-Star Medical Incorporated and uses polysulfone hollow fibers similar to most of our hemofilters. It submits the leukocytes to a low calcium environment during regional citrate anticoagulation and low shear stress, which causes that the leukocytes to be adsorbed along the outer walls of the polysulfone fibers. A 2-arm randomized control open label trial was started in the United States in 134 patients. The patients had to be receiving CRRT for a minimum of 4 hours and not more than 24 hours, and the primary outcome was all-cause mortality at 60 days with several secondary outcomes. An interim analysis was done with 134 patients, and the trial was terminated because more than 70% of the patients did not achieve the target calcium levels that were required for the leukocytes to become apoptotic. So, for what was analyzed, and this is what was done, they analyzed the patients. There were 65 in the control group, 69 in the SCD group, and the per protocol analysis had 27 patients in the control group and 19 patients in the SCD group. When they looked at what happened, there was no difference in the 60 per day mortality as in the group as a whole, but there was a slight difference. The hazard ratio for 60-day mortality in the group which achieved the necessary calcium levels, it was 0.46, and the 95% confidence interval of course crosses 1.65, crosses 1, because the number is really too small to have a significance. Another study by Stuart Goldstein's group looked at the SCD in critically ill children, published in Kidney International Reports in 2021. It used acid citrate dextrose adenine as the regional citrate anticoagulation, and only polysulfone based membranes were used. The primary outcome of this study was the safety of the device, and there were no device related serious adverse events. There were 40 overall events observed, but none of them were related to the device. Now, as compared to the earlier randomized study, in the pediatric study, they were able to show that the circuit ionic calcium levels were able to be maintained 90% of the time. So, this is feasible, but as the sample size was very small, only 16 patients, it was considered that this study wasn't powered to show any mortality benefit. Nevertheless, the survival of patients in this study was 75%, and all 75% had a complete renal recovery, which is normally not the case in this group of AKI patients. So, to summarize, there are some extracorporeal devices which may provide a way to capture pathogens, reduce the load as well as downstream events. They may be mainly for use as an adjunct to all the good practice guidelines, all the antibiotic and supportive therapy which already exists, and may be useful where the therapies as known are either unavailable, ineffective or suboptimal. I hate to end a talk like this by sounding a word of caution, but we need large randomized trials with clinically important endpoints. 20 years ago, we started with high volume hemofiltration, hemoperfusion, we had high cutoff membranes like Septex, then we had coupled plasma filtration, adsorption, and we've given up all of these treatments over a period of time because they weren't found to be useful. Either the studies had to be stopped early because they couldn't recruit, or some of them like coupled plasma filtration, adsorption were actually stopped because there was a signal of harm. So as with any new therapy, we will need hard evidence before we start using them. Thank you.